There are three words that can help you fight cancer. Know your risk. There are three words that can help you fight cancer. Know your risk. It seems simple, right? But how do you know your risk? For starters, here are some factors that may increase your risk of cancer. Family history, smoking, overweight, unhealthy diet, lack of exercise. If you are at risk, talk to your provider about appropriate screenings. You can also assess your risk through our online health risk assessment tool at adena.org/findout. Knowing your risk and getting your screenings are essential for early cancer detection. And early detection is your best chance of fighting cancer. Talk to your provider about your risk or call 740-779-FIND-3463 to find a provider and be proactive about your health.
Good afternoon and welcome to Living Well with Adena. I'm Dr. John Gabus, Medical Director of Community Partnerships. Today's topic is cancer screening. We have with us today Dr. Alex Wilson, who is the Medical Director of Adena's Cancer Program. As always, we encourage you to send in your questions in the chat box or messaging, and we will get to those questions a little bit later in the show. So Dr. Wilson, welcome.
Thank you.
So glad to have
be here.
Tell us a little bit about yourself and how you ended up here in Chillicothe.
Yeah, I grew up in Kentucky near the Ohio River, and went to University of Kentucky for all of my training. And was looking for a spot to practice that had a great cancer program history, had the technology I needed to treat most types of cancer well, and use my training to the best of my ability. Mm-hmm. And in a smaller community, more like where I grew up. And so then I ended up here in Chillicothe. How I was led to be an oncologist. I had a lot of experience personally with my grandmother who had a neglected breast cancer and had stage 4 breast cancer, and lived with her, and then several other family members who had a lot of experience with radiation treatment. So that's kind of ended up here treating cancer.
And we're so glad that you are here.
Oh, thank you. Glad to be here.
You do a very good job.
Mm-hmm.
So we're talking about screening, but one step just prior to screening would be prevention. It's always better to prevent a disease or an illness rather than have to treat it. So I want to refresh your memory about what you just saw on risk factors. Family history is a risk factor, sedentary lifestyle, being overweight, not moderating your alcohol intake, and the foods that you choose to eat in your diet. That all can have an impact on your risk of cancer. So let's talk about screening for cancer. And let's start with men. Their list is just a little bit shorter than women. What screenings would there be for men that are specific to men?
So there's prostate cancer screening with PSA blood tests. PSA is a compound that's secreted by normal prostate, but then also by prostate cancer cells. So there's a normal level of PSA in men, but it's recommended that baseline be checked at about 45 years old. And then recommendations from there depend on the level of that PSA. If it's very, very low, it may not be required to be checked for several years, or if it's a little higher, maybe once a year, and very rarely at initial baseline checking of the PSA would you be recommended a biopsy or something like that. The PSA tests, I like to mention, a lot of people have heard about PSA. It can be variable, it can change, but it's still useful as a screening tool. We've just learned better how to use it.
Mm-hmm. And the importance of tracking it over time, I think, is probably where the most value comes from that.
Absolutely, yeah. So that's why I think that this baseline level is really important. It's say 45, so you know, if you go in at 55 and have it drawn, and it is higher, it's a little higher than expected, you know what the change is, because the change really matters with PSA and prostate cancer. So you can't really get that information unless you've had a nice baseline when you're extremely low risk.
Okay, great, thanks. And on to women. Men are a short story. Women are a much more detailed story of cancer screenings. So we have breast, ovarian, and endometrial or uterine cancer. And I know as a family physician, keeping up with when you're supposed to screen for breast cancer with a mammogram, that's been moving, it's been a moving target. And I'd like to hear your thoughts about screening for breast cancer in women.
Yeah, so the most recent recommendations stay really about 40 years of age to start mammography screening for breast cancer. And then typically annually, as long as a woman is healthy, and can be, a little less frequent as a woman gets older. So really, but the important thing is to know that you're to start about 40 if you're at normal risk or average risk. So if there's a family history of breast cancer, which many of us know, family members, sisters, grandmothers that have had breast cancer, it's important to talk to your doctor if that's a concern for increased genetic risk, because that could dictate, meaning an earlier breast cancer screening or a different kind, using a different modality besides mammography.
Okay. Are there different types of mammography techniques, and what's better with one versus another?
Yeah, so there are. If you look at mammography, it can be very confusing because you have digital mammography and kind of older school film mammography. Then you have tomosynthesis mammography. In short, the latest technology is tomosynthesis mammography. And the reason that's a little better than traditional mammography is your radiologists can then kind of scroll through the images. They can see the breast in 3D rather than a 2D image. So historically, you could only see 2 views of the breasts, and you could not really take a closer look if you're worried about something, except with an ultrasound. But now with tomosynthesis mammography, which we use here at Adena, you can detect even smaller lesions. So frequently in our breast cancer clinic, we'll see 2-millimeter breast cancers detected on mammography, which was unheard of in the past.
Wow. So that's been a technological advance that's helped with screening for breast cancer in women.
Absolutely. And if it's detected at such an early stage, often there's not even a thought of suggesting a chemotherapy treatment. And I think that's important to mention. Treatment can be so much less if these breast cancers are caught extremely early.
Okay, great. And I also know that there's not really good techniques for screening for ovarian cancer in the common population. There are people who have a genetic predisposition to ovarian cancer. Can you take us through the spectrum of average risk and high risk? How would you screen for that in those 2 patient categories?
Yeah, so with an average risk person, ovarian cancer screening has typically not been shown to be beneficial. As far as there is an approach that's been investigated, transvaginal ultrasound. But in someone who has a genetic mutation and predisposed to ovarian cancer, such as BRCA, there are options for screening and or prophylactic removal of the ovaries before cancer is there. So a hysterectomy just to prevent cancer from developing in the ovaries. So if a woman many women who have that mutation and predisposition choose to have the surgery, in which negates the need for screening because you don't have ovaries anymore to develop ovarian cancer. But in lieu of that, if a woman does not want a hysterectomy, you can screen with a transvaginal ultrasound annually.
And one of the things that we didn't talk about at the beginning, what are some of the criteria that go into a screening test versus a diagnostic test? Because if you're screening for something that there's no cure for, like let me think of a non-cancer example, Lou Gehrig's disease or ALS, there's not much that you can do about it. So I imagine that factors in part of the thinking about what is an appropriate screening test.
Yeah, absolutely. Yeah, it seems kind of the opposite of what we would think to say, oh, we're not going to screen for that cancer because for any reason, really, everyone would want the best screening for every cancer if possible. The issue that when you look at a screening test is that are you detecting a lot of false positives, meaning you screen for ovarian cancer and you see something abnormal and you end up with a hysterectomy, but there's no cancer there. Or you end up with a biopsy and there's no cancer there. Or you end up with 6 doctor visits and it turns out to be nothing. That is a big part of understanding whether or not a screening test is valuable. The other thing that plays into it is the incidence or how common a cancer is. in a population. So that's why for some of these cancers, we'll talk about lung in a minute, but there are criteria to screen for the cancer, because we know if you have XYZ criteria, say you smoked for a long time, you're more likely to have a lung cancer. So a screening test is more likely to help you than hurt you, because every screening test has a potential harm. For most of them, it's additional biopsies, additional surgeries, additional worry, anxiety, time off work, and all those things really matter. So if we're going to screen for something, we want to make sure that we don't send you down a path that is where you don't get any benefit out of it. Or if you have a cancer, for instance, that's typically incurable, or a disease that's incurable, and it's not important to screen for. As we get better treatment for different cancers, there are more screenings. And so you'll see this list of screenings increase with time, because as we can treat more people effectively, it makes a lot more sense to screen someone if we can have a pretty low impact treatment for people to get rid of it.
That's a great compare and contrast with why we do a screening test versus a diagnostic test. Okay, one last area for women, and that's uterine cancer. Is there a screening test for uterine cancer?
I mean, typically folks aren't screened for uterine cancer. It tends to present with uterine bleeding. It tends to present with symptoms. However, again, you can be at higher risk for uterine cancer. And so there are ways to kind of be more proactive with your OBGYN regarding uterine cancer risks, talk about symptoms. One of the more definitive ways to screen for uterine cancer, again, is transvaginal ultrasound. But it's a fairly rare cancer. So we're going back to the reasons you would screen for a cancer. And so it's pretty rare. So it wouldn't make a whole lot of sense for everybody to get that ultrasound in with a biopsy potentially. But if you do have a mutation that can predispose you to it, there are options of hysterectomy or transvaginal ultrasound or some endometrial biopsies from time to time.
Okay, thank you. It's good to hear that it's a rare cancer. But once again, if you have any symptoms that you're not quite sure about, it's important to reach out to your primary care provider to get those questions answered. So if you're feeling anxiety about a symptom that you're experiencing maybe for the first time, or it's getting worse, please reach out to your primary care provider to get those questions answered and to be reassured. Most of the time, it is not cancer when you have some changes in your body habits. So now let's move on to kind of global cancer screening that affects both men and women. And one that I'm particularly aware of and sensitive to is colon cancer. When I was 37, I had colon cancer. And I know that for my family members, the screenings become different. So if you could take us from screening for a normal risk population, how can we do that? What methods are available? How do we move to high risk screening?
So, the recommendation for first colonoscopy currently is age 45 for the normal risk population. If you are averse to colonoscopy or have had a bad experience, a lot of folks aren't interested in that method of screening. There are ways to determine if you really need a colonoscopy as an alternative. One is the fecal occult blood test, which is a blood test that can be done in your doctor's office that looks for blood in your stool. And if you see that, then you can move on to a colonoscopy or another test. And that there are ways to look at this and try to determine if you really, really need a colonoscopy versus just going straight for that. However, a colonoscopy is the best test. It is not only preventive, but it actually removes lesions that become cancer later on. And that's why it's such a great test. When they do the scope in there, they're taking out polyps, and polyps can very frequently and eventually will become cancer. So that's just an important distinction to make. Another alternative is something called Cologuard, where you can send your stool off to a laboratory, and it kind of goes through a bunch of genes that can be present in cancer cells. And it can say, oh, there's some cells in there that are abnormal, some abnormal genetic mutations. And then at that point, you could have a colonoscopy. So I think the important message is that colonoscopy, there's no test that can beat colonoscopy, and it's well worth it, in my opinion, because again, if you catch that early, sometimes the only treatment for a cancer in the colon is that they take it out while you're in the colonoscopy, and you get another one a few years later. And then that prevents the need for a big surgery chemotherapy. The treatment for colon cancer can last 3 to 6 months if you need chemotherapy. So you're really better off to just go ahead and have the colonoscopy. If you're averse to it, there are alternatives you can talk to your doctor about. I'm sure they'd be open to. I think we're all more than happy to go with alternatives rather than nothing at all, because I think that can bring out and help you decide when to kind of pull the trigger on the colonoscopy. So that's for an average risk patient. For a high risk patient, so a patient whose family member has had a colon cancer, say your father or mother, brother, sister, first degree relatives, then oftentimes you will get your colonoscopy 10 years from the time they had their cancer. So if they had their cancer at a young age, you would potentially get your colonoscopy much sooner. Other high-risk conditions, there's a few genetic mutations and conditions that can be detected on colonoscopy or detected on your tumor specimen if you have a tumor removed, called Lynch syndrome and familial adenomatous polyposis, FAP. They have different screening recommendations also that are kind of more stringent. And those are rare conditions. And most folks know if they have a strong history of colon cancer and would have an idea that they may have that.
Mm-hmm. Thank you.
Mm-hmm.
I know my poor kids have to start at age 27.
My goodness.
And they were colonoscopy averse at the beginning, but when you talk about what's involved with that, it can be reassuring to know that really the hardest part is the preparation. The colonoscopy is probably the easiest part of that. And really how I think about it, and with my own personal context of having had cancer, is I'm very happy to give up about 10 or 12 hours of not eating and getting prepped for a colonoscopy to know that my cancer risk is still very, very low. So I would encourage you to reach out to your primary care provider. Make sure that if you haven't had your colon cancer screening, that you do get started. We haven't really talked about the pandemic and its impact on screening. We'll save that till the end, but as a reminder, we should talk about that at the end. Also a reminder, if you have questions, please submit them through the chat in the messaging portal, and we'll get to those and answer your very important questions. All right, so we've talked about colon. I know in Appalachia, we have a lot of people who smoke. And therefore, I think we have a lot of people who have lung cancer. Is that right?
Absolutely. Yeah, we have a much higher incidence here than the rest of the country.
And how does a person get screened for lung cancer?
Yeah, so with lung cancer, this is a fairly new screening tool. I would say the past 10 to 15 years, but this was not done previously. But there's a CAT scan that's kind of a special CAT scan, meaning that you don't get as much radiation dose with the CAT scan as you would typically. And you don't have to do the IV contrast for it. It takes you come in to get it, it takes probably 15 minutes the time to hit the door, the time you leave. You get a CAT scan once a year, and maybe more frequently if you have lung nodules. So what a CAT scan is a pretty detailed three-dimensional picture of your lungs, and they can see little nodules, even 1-2 millimeters. So the recommendation for age is ages 50 through 80. You have to have about a 10 to 20 year history of smoking. You call the number and they help decide if it's enough years. If you smoke for 20 years, you definitely qualify, almost definitely. If you smoke for 10 years heavily, you will qualify. But it will start at age 50 and it goes to age 80. And this is such an effective screening tool. They just expanded the ages. It was 55 to 74, and they decreased the amount of smoking to qualify for it. Also, if you quit in the past 15 years, you still qualify for this screen. You're still unfortunately at risk for lung cancer, but it's still the best thing you could have done for yourself. It decreases your risk of subsequent lung cancers, and it also improves your lung function, and can, more importantly, stop the decline of your lung function from a condition called COPD that's caused by smoking. So this screening test, I think, is very powerful. And I'll be honest, if I have a patient come in with a very, very small breast cancer or a very, very early stage prostate cancer and they smoke, I spend more time talking about lung cancer screening than I do about treating that cancer, which is 90% curable most of the time. Lung cancer is a much more difficult disease to cure. You follow these really tiny nodules till they're about 1 centimeter or 8 millimeters, smaller than a pencil head. And then we have very, very effective treatments for them when they're very early. Unfortunately, with lung cancer, you don't see it, hear it, feel it. It's insidious. It comes on, and by the time you have a symptom, it's unfortunately spread. So, this screening to me is one that it's very critical for this area. And if you have a friend or loved one who smokes and they're age 50 through 80, I would encourage them to seek that out through their primary care doctor.
Okay, one of the risk factors for multiple cancers is cigarette smoking. You can access a quit clinic that we have at Adena through your primary care provider. You can also access government resources at 1-800-QUIT-NOW, 1-800-QUIT-NOW for help in quitting smoking. That's the best thing you could do for helping decrease your risk of multiple cancers. Now, I know that there are some people who have blood cancers, but I don't hear about screening for that. Is there a screening protocol or a program for leukemia, lymphoma, anything that has come about in the last few years?
Mm-hmm. Yeah, unfortunately, I haven't seen or heard a new screening program for these blood cancers. I will say that the more aggressive blood cancers, you very quickly have symptoms. If you have an aggressive blood cancer, you don't feel well, and you will seek out your physician to help you with that. Folks just don't let those go because they just feel too bad. With a low grade or a lymphoma that can go on for years and years, frequently that's kind of caught incidentally. If you go to the ER or you just see your primary care doctor and you're kind of fatigued or not feeling well, you often get a blood test that can detect that. I think, we talked about the difference between a screening and a diagnostic test earlier. Mm-hmm. And I think the reason screening tests are difficult for these is the curable leukemias are, they come very quickly and you do have symptoms and you will get checked out. And the ones that are low grade and more incurable, they tend to not kill you. It's something you can live with and be treated, and that you have time to have that detected before it becomes very, very aggressive and have it treated. Mm-hmm. So I'm not sure a screening test will be coming soon for blood cancers.
Okay. One of the things that is constantly changing is technology. Mm-hmm. And ways of detecting cancers. Do you have any insight on what might be on the horizon with technology, whether it's a different imaging technique or blood testing for cancer screenings or cancer detection?
Mm-hmm. So there's new imaging all the time. Imaging is a very powerful way to detect cancer, and they're finding ways to do imaging in a more inexpensive fashion, which is important for a screening test because it's hard for patients and insurers to pay for an expensive test annually. So I think with imaging getting less expensive, I think there'll be a lot more imaging tests, for example, MRI for pancreas cancer on the horizon, but also liquid tumor biopsies, detection of abnormal mutations or abnormal cells within your bloodstream that could then point you to an imaging exam. That technology is rapidly improving. We're not there yet, but I think there will be further refinement of that. There are, PET scans or scans that detect active cells within the body that are actively using a lot of glucose and or another substance that you can kind of label with a radioactive tracer. And there are different types of PET scans coming out as well that I think may be useful for screening and or additional workup should you have a blood draw and they find an abnormal cell. I think there might be a PET scan for many types of cancer that's specific that will help us detect those earlier. So I think there's a lot of hope to detect things earlier. I've seen a lot of change even the past 12 years since I've been an oncologist. So I'm hopeful to see the same amount of change over the next 12.
Mm-hmm. When I started practice 1 or 2 years prior to when you started, I sensed in my patients that if you talked about lung cancer, it was basically a death sentence for them because it did present at an advanced state, and the treatment then was much more aggressive but not as effective. So I think getting this early detection through screening really gives patients more flexibility, more options, more choice in how their cancer is treated. Is that fair?
Yeah, that's absolutely fair. I think, if you're someone who likes to kind of take the reins and have options and control, what happens to you as far as your health care, an early stage cancer, you often have 2-3 options to kind of work through and talk about risks and benefits, pluses and minuses. And if it's a small cancer, you have time. You have time to talk about it with your friends and family. You have time to research it. You have time for a second opinion. I think catching it early just really opens a lot of doors for people to have their body treated the way they want it to be treated. I think that's really important. So I do, as an oncologist, people come in and think, oh, this doctor is used to doing very toxic treatment on people, and it's something that they do here. But really, we want you to have the least toxic treatment possible. And the way to do that is to catch it early and to have you more involved in the care. Advanced cancer is often there's one way to treat it, and that's kind of all there is.
Okay, thank you. One of the last areas that we haven't talked about yet is pancreas cancer. And it's a rare cancer, but boy, when it's diagnosed, it's devastating. And could you talk about, is there screening for pancreatic cancer? If not now, is there something, and you may have alluded to that, is there something on the horizon for pancreatic cancer screening?
Yeah, so I think the way we kind of see the screenings develop is the high-risk population gets it first. So the people that have the mutations that predispose them to pancreas cancer do have a screening test. They do have MRI of the pancreas done in a slightly modified and faster fashion, in addition to something called an endoscopic ultrasound, where they take a picture kind of through the stomach and the bowels to look at the pancreas to look for small lesions. Pancreatic cancer, much like lung cancer, you don't feel it or see it until it's very advanced typically. So I think there are things on the horizon in addition to the liquid tumor biopsies down the road that I think potentially could help us detect this sooner. So yeah, there is a screening test for folks at high risk. They're able to get this, and it's part of the BRCA mutation group, and those folks get that annually.
Okay, thank you very much. All right, skin cancer we haven't touched on skin cancer. Obviously, we can prevent a fair number of skin cancers by using sunscreen and wearing sun protective clothing. What are some screenings that go along with skin cancer?
Yeah, so the best screening, is to have an annual examination with a dermatologist to screen, or your family doctor, and to look for, small moles or lesions that can be followed over time, because much like the lung lesions I talked about being very, very small and followed over time, that's what really, in getting a baseline of how your skin looks or how your lungs look or what your PSA is, getting that baseline when you're younger, 20s to 30s, with your skin doctor, to kind of examine all the areas, even the areas you might not think about there being skin cancer, like in the scalp, but behind the hair, areas that you may not see in between the legs, things like that. It's important to get those screenings. I think, and then one area people forget to cover all the time in the sun, particularly with it being summer, is, wear a hat when you're outside. A lot of the skin cancers I end up treating as a radiation oncologist that are advanced are in the head and neck and scalp, because it's just an area we neglect to cover.
Okay, and I know that there are two cancers that I have the most respect for. The first is pancreatic cancer, and the second is malignant melanoma, which is the most serious of skin cancers. So prevention, key. Family history is important with melanoma, and making sure that if you have any areas on your skin that are growing or changing or are very darkly pigmented, you point that out to your primary care provider or a dermatologist so they can examine it more fully and potentially take a biopsy. We have a couple of questions, and then we'll get to the pandemic impact on screening. Once a doctor tells a patient they will refer for a colonoscopy, what are the next steps a patient can expect? Good question. There are two ways to access a colonoscopy. One is called the first access or rapid access, where you have very few risk factors. You're a healthy 50-year-old man or woman, and you don't take any medicines. You don't have any underlying health issues. Those folks can be referred from their primary care provider with just a phone call, and then the gastroenterology group or others who perform colonoscopies will contact you in a short period of time, usually no more than 2 weeks. If you haven't heard anything in 2 weeks, it's important to reach out to your primary care provider to double check and to advocate on your behalf. The other is when you are in with your primary care provider for an annual health maintenance visit, and it's time for that colon cancer screening, your primary care provider can make the referral to a gastroenterologist or another physician that does colonoscopies. And those are the two ways that it's accessed. Still, you can be your own advocate and have your primary care provider be an advocate. If you don't hear back in a few weeks, please call back and we'll make sure that you're scheduled for that. Because if we're screening, we want these screenings to be completed. And if we put any barriers in the way, people aren't clamoring to have colonoscopies. So we want it to be as easy and as simple as and as comfortable as possible. Hope that answered the question. Do you have to have a doctor referral to schedule a colonoscopy? Kind of very similar. You can do direct access. I use the word rapid access. It's direct access. If you were to notify the gastroenterology group that you're of normal risk and it's time for the first annual screening or follow-up screenings. So those are ways to handle that. So we've been talking around a bit about the pandemic, and with social distancing and elective procedures being shut down, what impact are you seeing, or have you heard from your colleagues in all specialties? What's the impact on the detection of cancer? Or are you seeing advanced stage? Are you seeing any difference? What is your take on how the pandemic impacted screenings?
Yeah, I think we're seeing a lot more advanced cancers, or cancers that may have waited 3 or 4 extra months because, every doctor was on television telling everyone to stay home. But then also you may have a visit with your doctor on the phone and they say, come have your screenings. And then I think folks knew that our COVID patients were hospitalized in the hospital, and the doctors may be seeing those patients in the office. I think there's a fair amount of apprehension about seeing a doctor face to face and having a procedure, and all that is understood. But there's been a large decrease in the number of people being screened, and I'm seeing on the back end, unfortunately, a lot more patients I'm seeing out of the hospital. I'm seeing them very sick when they have a very advanced cancer versus something that can potentially be cured. So it's been a very sad few months for me, and I think it's understandable, but that the hospital's been a very safe place, and we're taking all the precautions, and it's just more important for your personal health at this time to get vaccinated with the COVID vaccine, and then come in and have screenings as recommended.
Okay, thank you. It is important. Whenever you are behind on your screenings, that's giving the cancer a chance to get a foothold if you are predisposed to a cancer. So it's very, very important to get back on track with your screenings, whether it's through your primary care provider, OBGYN, or other healthcare provider. We have another question. I'm 47 years old and my dad passed away from colon cancer at age 63. When should I have a screening?
So the screenings start for average risk at age 45. So I think we're already within the window for average risk. But with your father having had colon cancer, it's just more important that, even though the timing is the same, it's more important that you go and have that done. And you do see colon cancer very frequently run in families, even outside of the known mutations. We know some mutations that predispose, but just the fact that your dad had it would tell me, oh, you should go as soon as you can and start the screening process, and let folks take a look and perhaps remove some polyps that might be precancerous and decrease your risk.
And the screenings specifically for colon cancer, if you find a polyp, then and you have it and you're high risk, the screening time changes from 10 years to every 5 years, if I understand that correctly. Is that so?
That's right. Yeah. So for all of these screenings, if we find something, so we find a lung nodule, we find a polyp in the colon, then the frequency is typically 10 years or 1 year, but it gets sooner because that tells us that you're a little higher risk, and so you might need to be seen a little more frequently. And then I've seen some folks later that they were recommended to come back in 3 years, and they said, well, I'm going to do 10 years like everyone else, but your body's telling us that you need a little sooner. So that's even more important that you kind of keep up with that increased frequency of screening.
Right. Yeah, I'd rather have a colonoscopy than a recurrence of colon cancer. Or in my children, I'd rather have them have a colonoscopy than experience what I did. All right. Well, that brings us to the end of this episode of Living Well with Adena, featuring Dr. Alex Wilson, Medical Director of our Cancer Center. And we were covering cancer screenings and talking about risk and when you should be screened. If you have any questions, you can go to adena.org and seek out more answers. As always, we're so glad you joined us and glad that we had some important questions that came through. We'll see you again next time in 2 weeks.